Morning, everybody. I'm Dr. Neil Kalman, Chair of the Department of Family Medicine and Community Health. And we have a first this morning. This is the first time we've ever had a grand round speaker who's been so incredibly excellent and important to us that we've invited him back for a third time. And we're so fortunate that Dr. Krammer has been so gracious to be able to come back and talk to us about the status of these respiratory viruses that we're all concerned about, especially at this time of year. Dr. Krammer is the endowed professor of vaccinology in the Department of Microbiology at the Icahn School of Medicine. He received his advanced training in biotech and applied virology at the University of Natural Resources and Life Sciences in Vienna, and completed his postdoc work in the lab of Dr. Peter Police at the Department of Microbiology here at the Icahn School of Medicine. Since 2019, he's been the principal investigator in the Sinai Emory Multi-Institutional Collaborative Influenza Vaccine Innovation Center, which aims to develop improved seasonal and universal influenza virus vaccines. Dr. Krammer's lab, a part of the NIH-funded Centers of Excellence in Influenza Research and Surveillance, focuses on understanding broadly reactive immune responses against the surface glycoproteins of RNA viruses, with the goal to develop better vaccines and novel therapeutics. Dr. Krammer's laboratory's main focus is influenza, but he also works on coronaviruses, flaviviruses, hantaviruses, filoviruses, and arenaviruses. He's published more than 400 papers on these topics. At the outset of the pandemic, Dr. Krammer's lab quickly developed reagents and assays for testing and characterization of the immune response against the virus. The lab developed the first serological assay to receive an FDA emergency use authorization. Krammer's lab also contributed significantly to understanding the immune response to infection and vaccination, and has several vaccine candidates and therapeutics in development, including an intranasal vaccines that may block COVID transmission. Dr. Krammer is currently chair of the in vitro group of SAVE, the US government initiative, which is tracking COVID variants of concern. So we're really grateful to have you back again. We look forward to hearing your updated remarks and telling us what to do. Thanks.
Thank you very much for this nice introduction, and thanks for inviting me back. So let me try to share my screen. What I wanted to do today is to give an overview of what to expect from the coming season, from the fall and winter season in terms of respiratory infections. And there have been a lot of changes in terms of what vaccines and countermeasures we have available. And I also wanted to walk through those for COVID-19, of course, but also for RSV. And then in the end, I'll talk a little bit about influenza. So just my disclosures, Mount Sinai has filed IP on patent applications for antibody tests for SARS-CoV-2 and SARS-CoV-2 vaccines. And Sinai actually has spun out a company right now that's called CastleVax to develop intranasal SARS-CoV-2 vaccines. And I'm co-founder and on the scientific advisory board of that company. So I'm going to start with SARS-CoV-2 or COVID-19, and I'll start with an update on how it looks right now. So for most of us, in a way, the pandemic is over. The WHO has not declared the pandemic over yet, but I think we're all aware that at least the intensity of the problem has been reduced quite a bit. So if we look globally, there were so far about, I would say 700 million official infections. You can see the infections or cases per day over the course of the pandemic here on the left side. Of course, right now we have to take that with a grain of salt because there's not much testing anymore. But you can see that, we had the last wave basically this spring, and there's not much going on right now, which again could be biased by less testing. But if you look at deaths, officially we had about 7 million deaths, COVID-19 deaths worldwide so far. And deaths are easier to detect, I would say. And we see that the number of deaths per day also went down quite a bit. So we're actually in a pretty good situation right now. And the impact of SARS-CoV-2 or COVID-19 is not comparable anymore to what we had from 2020 to 2022. In the US, the estimate is that approximately almost 1.2 million people died of COVID-19. So these are all official numbers. There's also estimates based on excess deaths, and the current best estimate for global COVID-19 deaths is about 27 million, which is substantially more than the official number. It's probably closer to the truth. And this is a large number, but it's still small compared to what we have seen in 1918 with the H1N1 influenza pandemic, which probably caused around 40 million deaths, but back then the population was much smaller. But again, this is a really significant number, and I think since the 1918 pandemic, this was the worst respiratory virus pandemic we have experienced. We're all aware the pandemic started, and then in the end of 2020, we started to have access to vaccines, which really worked well in the beginning. But also in the beginning of 2021 or end of 2020, we started to see the rise of variants of concern. We all remember the first ones were alpha, beta, gamma, and these variants actually had relatively little influence on protection that is afforded by vaccines. The Delta variant, which also came in spring and then summer of 2021, caused more breakthrough infections, but still not large numbers. But when it got tricky in terms of vaccine protection, breakthrough infections was actually in fall of 2021 when the Omicron variants hit. It started with the BA.1 subvariant, and now we have a lot of different Omicron variants that are circulating, and they are very good at causing breakthrough infections. And I think that's what a lot of us see, that people have little protection from symptomatic infection. That doesn't mean that they're not protected from severe disease, but again, these variants are really good in causing breakthrough infections and circumventing vaccine-induced immunity. The same is, by the way, true for reinfections. Before Omicron, an infection gave you reasonable protection from reinfection, but with Omicron, that effect basically disappeared and reinfections became very common too. What I wanted to stress is that even though these variants, these Omicron variants, can cause a large number of breakthrough infections, the vaccine still protects us from severe disease. And I'm usually trying to show this with the example of two countries that had been very good at keeping SARS-CoV-2 out until Omicron emerged. And these two countries are Hong Kong and New Zealand. They're approximately, in terms of population, the same size. What I show you here on the left side is basically SARS-CoV-2 cases in their initial Omicron outbreaks, and this is normalized per million people. And you can see these two curves here. You have a relatively sharp, relatively strong wave in Hong Kong. The wave has a little bit of a different shape in New Zealand, but if you do the math, it's approximately the same number of cases. And so these are the cases on the left side. And then on the right side, you have deaths per million people in Hong Kong and in New Zealand. And what you can see here is in New Zealand, that's the green line, barely anybody died in this Omicron wave, while in Hong Kong, there were a lot of deaths. And the reason basically is that in Hong Kong, the vaccination rate in 80-plus-year-olds was approximately 30%. And in New Zealand, it was almost 100%. So the vaccine didn't match Omicron. There were a lot of infections, as you can see on the left side, but vaccination really basically saved people from progressing to severe disease. And we see this effect also nowadays. So the take-home message is a lot of the vaccine-induced immunity doesn't protect us from infection anymore, but it does protect us from progression to severe disease. Before I go further with variants and vaccines and vaccine updates, I wanted to go back and look a little bit into how these variants are generated, and that's important also for physicians at Mount Sinai. So typically, RNA viruses, and SARS-CoV-2 is an RNA virus. When they replicate their genome, they have a very high error rate. So there's a lot of mutations, and if you have immune pressure, there can be escape mutants, right? And that's what we think these variants are. But coronaviruses are exceptional in that they have proofreading activity that's super rare for an RNA virus. But when they copy their genome, they actually repair or correct mistakes. And so the initial assumption was that they wouldn't mutate as fast. But of course, if you have many infections, millions of infections worldwide, you get still mutations, because every replication cycle of the virus allows the virus to mutate, even if the mutation rate is lower. But what was observed also relatively early in the pandemic was that there are patients that are immunocompromised that get infected and then are persistently infected. And so this here is on the right is from a New England Journal of Medicine paper already from 2020, where a patient was infected for 150 days and couldn't clear the virus. And in this case, mutations accumulated, and these are the same mutations that then showed up in the early variants of concern. So our idea is currently that these variants of concern are really generated in immunocompromised patients who are persistently infected. This can be people with uncontrolled HIV, transplant patients, people who have lymphomas, for example. And then these mutations accumulate, and in some cases, then these completely mutated viruses start to transmit in the population and can cause new waves and can also escape immunity. The reason why I bring this up is this is not just something that happens somewhere and then sometimes we get a variant of concern. This is actually happening at Mount Sinai too. What I wanted to point out here is a publication that was put together by Viviana Simon and Harm van Barkel here at Mount Sinai. And they found basically early in the Omicron outbreak or Omicron wave, a patient who was infected for 81 days with the original Omicron strain, and that strain started to mutate in that patient, acquiring 8 additional mutations in the spike. And then you see here a phylogenetic tree, basically, where we have patient 1. And this virus was then transmitted also to patient 2 and the patient 3 at Mount Sinai, where it further mutated. And then it was found in the population as well. This didn't become a new variant in the end. It died out. It was probably not fit enough. But this basically shows you that these variants can emerge even under our watch. And so far, there are no good studies and no clinical trials that basically provide methods of how to get rid of these persistent infections, right? Of course, you can treat with Paxlovid. You can hope that immunity at some point kicks in and then a strong immune response clears the virus. But I think a lot of more research is needed to figure out what to do with these patients and how to get rid of their persistent infections. And actually, I wanted to put a plug here for research that Viviana Simon here at the department is doing. They actually have funding right now to look into a lot of these viruses and to try to understand the mechanisms, how they are generated. So if you have patients who are persistently infected and who might be interested in participating in research projects, you can just contact Viviana. Going back to the variants, became very complicated at some point. There's a lot of diversification, and I like to show this slide that's from an Italian researcher that shows you how complicated it really became with variants of concern, right? And what you see here are basically all subvariants that go back to the XBB subvariant of Omicron. So it's very complicated at this point in time. There's a lot of subvariant out there. And it's actually too complicated to follow, sometimes even for me. But there are a few that we have to keep an eye on, and I'll cover them quickly. One scary moment actually was a few months ago when a new variant was reported that actually had nothing to do with the variants that I'm showing here. It wasn't derived from XBB. It was derived from an older Omicron version, from BA2. And so this virus, this variant was called BA2.86, and you might have heard about it because there were actually stories in the media about it. And the reason why people were concerned was because this variant had, again, a large number of mutations in its spike protein. If you compare it to the ancestral spike, this is shown here on the lower, in the lower graph, there were 66 mutations. If you compare it just to BA2, which is the subvariant of Omicron, which is its ancestor, we have 39 additional mutations. And again, there was a lot of worry that we are going to be back in a situation like with Omicron, where somebody that has completely changed shows up and then causes a huge wave and basically breaks through vaccine-induced immunity. But the good thing is that when people started to look into neutralizing antibodies against this newly emerging BA2.86 variant, it became clear that it can actually be nicely neutralized. So here we have sera from individuals, a number of individuals taken 3 weeks after the bivalent booster. You can see the neutralizing titer is the highest against the original spike, but also good against BA1, BA2, BA5, lower against XBB and the currently circulating variants, but not much lower against BA2.86. Actually, BA2.86 is getting neutralized a little bit better actually than what's currently circulating in humans. So from that perspective, it was good to see that this virus would get neutralized by our immune responses. And the other good thing is that we have now tracked this virus for a few months and it doesn't seem to expand, but it caused a relatively large scare. And the US government was also very worried about it. If you look at what's actually circulating right now, all these viruses that are prevalent right now, all these variants are derived from the XBB sublineage. And the most prevalent ones at this moment in time are EG5, FL1.5.1, and HV.1. So you can see that here, this is EG5, this is HV1, and this here is the FL.1.5.1. The good thing is that they're all still closely related to the XBB.1.5 strain, which is in the vaccine. And before there was vaccine data, people looked at, how an XBB infection would increase titers against these variants that are currently circulating. And so what you see here on the left side is basically neutralizing antibody titers of people who, got a bivalent vaccine, but had no XBB1 infection. And you can see that the titers against EG.5.1, for example, are relatively low, right? Or against FL1.5.1. If you compare that to people who had an XBB infection on top of their bivalent vaccine, you see that these titers are quite a bit higher. So it goes, they're double or triple what you would see without the XBB infection. That doesn't mean you should get an XBB infection. XBB itself is not around anymore. But what it suggests is that a vaccine that includes the XBB spike would actually increase the titers, neutralizing antibody titers against these currently circulating variants, and that's good news. And so we see all this evolution ongoing, but of course the vaccines changed over time too. So just to go back to what happened with Omicron, so you remember the first 2 vaccine doses were rolled out, and there was a recommendation for a third dose in fall of 2021. And then Omicron started to circulate. And of course, when people looked at the sequence of the Omicron spike, it became clear that this virus would escape vaccine-induced immunity. And very, very quickly, Omicron became the dominant virus globally, and the BA.1 subvariant of Omicron caused a massive wave already in the end of 2021, beginning of 2022. And because it was clear that this virus would escape vaccine-induced immunity, vaccine producers started to make vaccines that encoded the Omicron spike. They started clinical trials, and by May, they had results for the clinical trials that were then shared with the FDA, and then the FDA met and decided that the vaccines have to be updated. At that point in time, they recommended a bivalent vaccine that actually should include the ancestral strain and then BA.5. In the meantime, of course, a lot changed. The virus changed. We had multiple waves. And then in fall of 2022, as you remember, we had the rollout of the ancestral BA.5 bivalent vaccines. By that time, BA.5 was actually not circulating anymore. It had been replaced by other variants that had a strong escape phenotype. But of course, this is a very long time frame to update a vaccine. And so this time, this was much, much quicker. Of course, the WHO and also the US government, the CDC, are monitoring which variants are circulating. And so in early summer, there was a global recommendation by the WHO, but also by the European regulatory agencies and the FDA to update the vaccine to a monovalent vaccine that contains the XBB.1.5 spike, which was the most prevalent at this point in time. And then the vaccines were updated very quickly. And as you remember, a few weeks ago, these vaccines were licensed in the US. First, we saw licensure of the Moderna vaccine with the XBB.1.5 spike, and then the Pfizer-BioNTech and the Pfizer-BioNTech with the XBB.1.5 spike that was at the same time. And then a few weeks later, the Novavax vaccine, which is different. It's not an mRNA vaccine, but a recombinant protein vaccine, was also licensed. The Moderna and Pfizer vaccines are now available. I think Novavax is entering the market now, but they usually have way fewer doses, so this is harder to get. Again, as a reminder, we think the XBB.1.5 spike in the vaccine is still a good choice because we have seen that an XBB infection really induces or increases titers against the currently circulating variants. But there's also more data about this. So this is from a preprint that Moderna put out. They did a clinical trial with their monovalent XBB.1.5 vaccine. And what we can see nicely here is that this vaccine increases titers against all the current circulating variants that we are worried about. Of course, you see an increase in neutralizing antibodies against XBB.1.5 of about 10-fold, which is good. But even if you look at EG.5.1, you see an 11-fold increase to a level that is similar to what happens with XBB.1.5. You see a similar increase against the FL.1.5.1 variant, which is also circulating right now. And even against this BA.2.86 variant, we see a very nice increase. So currently, if the variants that circulate don't change too much, the prediction would be that the vaccine will work really well. But of course, there's a lot of discussion about what we do moving forward, right? And so currently, it looks like we will see annual updates for the SARS-CoV-2 vaccines and a recommendation for annual revaccination. So very similar to what we do for influenza. And we have to do that for influenza because the virus changes and SARS-CoV-2 seems to change at a high rate too. So in a way, it makes sense. And of course, if people know that there's an annual update and that you have to get revaccinated every fall, you can schedule that. And from an administrative point of view and from a rollout point of view, that's of course relatively easy. But there's a lot of open questions about that. And the same questions are true for influenza. The first question is if this annual vaccination is a good idea for everyone, or if we should focus on people who are more vulnerable for these infections. The other question is, what happens if, let's say, a more pathogenic variant shows up during the season, let's say in I don't know, January? Is there a way to respond and update the vaccine quickly? And that's something that I guess the vaccine producers also need to work on. And if that is the case, maybe it would make sense to then get 2 shots of that vaccine. If the virus dramatically changed, maybe it should be a primary immunization series again. The other question that we haven't answered yet, because there are no good direct comparisons, are the mRNA vaccines better for boosting, or would the protein-based vaccines be better? Vaccine be better, like the one that Novavax produces? And I think we need studies to really look at that if we, want to use these vaccines every year. And of course, one important point here is when we update the vaccines, and that's true for the bivalent vaccine that came last year as well. These vaccines are used in North America and in Europe, but globally they are basically not in use. And there is no availability, right? So how can we build a system in which we have global vaccine equity in terms of the updated boosters? And there's a big push to actually develop new vaccines that are broadly protective, where these changes wouldn't, make much of a difference, where the virus could change, but the vaccine would still work. So there's a lot of questions that are discussed in the community right now. And actually, I wanted to point out, we just published, Ali Al-Abadi, a colleague of mine from Washington University, and me, we just published a commentary yesterday in Science about that. So if you're interested in that discussion, feel free to look at that. It's relatively short, but it discusses these questions. The other problem that we see is that the vaccines that we currently use are injected vaccines, and they give us good systemic immune responses, but they're not very good in inducing local immunity in the upper respiratory tract. And we think that this local immunity in the upper respiratory tract would actually be very important for blocking infections, right? And also blocking onward transmission. And so there is a lot of effort now going into developing vaccines that could do that could induce immune responses in the upper respiratory tract. They are likely not going to be available next year, but the development timeline is a little bit longer. But maybe in 1 to 2 years, there could be first candidates on the market. Right now, there are large programs that receive funding from the US government to develop such vaccines. This was just kicked off. And so the hope is that there would be phase 3 results within the next 1 to 2 years. And just to point it out, Mount Sinai has a vaccine candidate in that game too. It's called NDV Hexapro-S. That was developed here at the department. It's the first versions of it were actually produced here at Mount Sinai in our GMP facility. And the first clinical trial was also run at Mount Sinai by Judy Aberg and John Liu. And so we're very proud of that vaccine, and we'll see how it does in phase 2 and phase 3 trials. So just to kind of summarize this SARS-CoV-2 part a little bit, where are we going? What's a realistic scenario? And then just going back to this, I think I showed that last time too. We have, in a way, 2 extremes when we look at seasonal respiratory viruses. On the one side, we have influenza, which causes seasonal epidemics with a substantial proportion of severe disease, and we need annual vaccination. And on the other side, we have human coronaviruses and other common cold viruses that also cause seasonal epidemics, but mostly cause mild disease, and we don't need vaccines for those. And the question still is, where does SARS-CoV-2 fall? And it's changing a little bit. It used to fall here on the other side of influenza. We used to be much more severe. Now it's similar to influenza. And the hope is that over time, with more and more immunity that's accumulated, that it would move to the right a little bit more and become more like human coronaviruses or common cold coronaviruses. But right now it's still a problem, and it's still more similar to influenza. So what's the outlook for SARS-CoV-2? We still have a hard time to predict its evolution. We have now variant-specific vaccines that hopefully this year will work well. But there are breakthrough infections, and breakthrough infections can result in long COVID, and long COVID seems to be a real problem. And there is still a lack of understanding of the mechanisms behind it. And as long as we don't understand the mechanisms, it's probably really hard to find specific therapies for it. Long COVID is likely different mechanisms that, cause different symptoms in different people. And so I think that adds to the lack of understanding, because it's relatively complex. The other problem that we have, and this existed before the pandemic too, is that immunocompromised individuals continue to be at high risk, even if the risk for the normal population or the healthy population is decreasing. And so we have to take special care of them. And the other point that I wanted to make is that even if the case fatality rate is now much lower than in the beginning of the pandemic, even if there's not a lot of severe disease or death, if you have a strong SARS-CoV-2 wave, that can still cause a problem for the health system. And that's, again, similar to influenza. When we have strong influenza waves during winter, that can still overwhelm, at least locally, health systems. And that's something that we have to keep in mind. All right, I'm going to move on to another virus that I'm actually not doing active research on, but I'm pretty interested in it. And we had a lot of movement with countermeasures against this virus. And this is respiratory syncytial virus, or RSV. So just a brief intro. What is RSV? RSV is a paramyxovirus that has a negative sense RNA genome. We have a model here on the left side. It says 2 glycoproteins on the surface, so basically 2 different spike proteins. And this model here on the left side looks nice, but in reality, RSV looks a little bit ugly, relatively irregular shaped. Here on the right side, you have an electron microscopic picture of a virion. And we have 2 versions. We have RSV-A and RSV-B. They are closely related but distinct, and they can cause a variety of diseases, from mild upper respiratory tract infections to life-threatening lower respiratory tract infections. And these infections are mostly a problem in very young infants, or in older adults or elderly, and in immunocompromised individuals. And so if you look at the CDC webpage, you'll find that we have between 8,000 and 80,000 RSV-associated hospitalizations, and between 100 to 300 RSV-associated deaths annually in the US in children below the age of 5. And of course, this is not a new problem. This is an old problem. And vaccines, people tried to develop vaccines already in the 1960s. And they tried that with the methods that they had back then, which was basically to grow the virus and inactivate the virus. The problem was, when they did vaccine trials, it turned out that the vaccine put the participants, which were kids, at much higher risk for severe disease, and there were actually deaths in that trial. So we saw vaccine-induced enhanced disease. And the idea is that this was caused by a polarization towards a Dh2 immune response. There's actually a very nice New York Times article that just came out, I think 2 days ago, that describes the situation back then. And if you're interested in ethics of vaccine development, read it. It's pretty interesting. But science moved on, and I'll tell you in a few seconds what the solution was for making RSV vaccines that work. But fact is that as of this season, we do have now 2 vaccines that can be used for different patient populations. And these vaccines are not based on inactivated RSV. They're based on recombinant F protein, so one of the spikes. And the vaccine is made in a very similar way as the Novavax SARS-CoV-2 vaccine. And so there's a lot of text here, but I'll walk you through it. So there's 2 vaccines now for individuals 60 years and older. One of them is called RSV Pre-F3 or RXV. I don't know, comes up with these names. This is produced by GSK, contains 120 micrograms of the pre-F protein, and it's adjuvanted with AZO1. And so when you look at the phase 3 clinical trial results, you'll see that the efficacy against lower respiratory tract disease in the first season of the vaccination was 82% or 83%. And in the second season, it went down to about 56%. So there's immune waning. And for these vaccines, we don't know yet how often people need to get revaccinated because of the waning. There's not a lot of data on this so far. And then there's a second candidate, which is called RSV Pre-F or Abrivso, that's made by Pfizer, and that only contains the pre-F protein, but no adjuvant. And that has shown in 60-year-olds and older, 88.9 efficacy in the first season and 78.6 in the second season. If you're interested in the data, the CDC has a paper out that describes this efficacy data and the trials. In addition to that, we have one vaccine, which is actually the same vaccine as used in the elderly, that can be used in pregnant women. And the idea here is to protect the newborns. And so these vaccines are recommended from weeks 32 through 36 in pregnancy, and from September through January, because RSV also causes most infections during the winter season. And so what was assessed in the clinical trials here, these phase 3 trials, was basically medically attended RSV-associated lower respiratory tract infections in babies born to these vaccinated mothers in the first 180 days of life. And they had an efficacy of 57%, which is not as high as we see in the older population, but still a significant efficacy. And again, there's a CDC paper that summarizes this. So these are vaccines, but we also have monoclonal antibody, new monoclonal antibody prevention that has been introduced recently, and that's nirsevimab, which was developed by AstraZeneca and Pfizer together. And so what this is it's a monoclonal antibody that neutralizes RSV. And it has been modified to have a long half-life in humans, right? Typically, typically monoclonal antibody would have a half-life of about 21 to 28 days. And so this antibody has a half-life of months. And so what you can do with this is you can give this to kids who are at risk before the season, and it will protect them throughout the season. And so the phase 3 data here is that it gave a protection of 79% during a 150-day period, so basically across the season, against medically attended RSV-associated lower respiratory tract infections. And it's indicated for infants under 8 months who entered their first RSV season and whose mothers did not receive the RSV vaccine. So if the mom is vaccinated, this is not indicated, but for kids who have been born by moms who didn't get vaccinated. And this is a 1-dose intramuscular injection shortly before the RSV season. And again, there's a CDC paper out on the efficacy and the safety of this in case you're interested. All right, and I said I would tell you the trick that worked and that made these vaccines work. I'll go back to SARS-CoV-2 for a second because the same trick was used there. And so typically when you have these spike proteins, right, these glycoproteins on the surface of a virus, they have often a function that they need to bind to our cellular receptors, so to attach to our cells. That's the first function. And the second function then is to fuse the viral membrane with the cellular membrane, right? So that the genome of the virus can get released into our cells. And so if you block one of these two functions, the virus becomes neutralized. It can't infect us anymore. The problem is the fusion step, because often these spike proteins are very unstable, right? So when they perform this fusion step, they flip over from the pre-fusion conformation to the post-fusion conformation. And the post-fusion conformation is, kind of the end for this glycoprotein, right? And so antibodies that bind to the post-fusion conformation can stop, binding of the virus to our cells, and they can't stop the fusion step because that already happened, right? And so what you want is, you want the vaccine to contain only pre-fusion spike, because you will get a lot of antibodies that block attachment of the virus to our cells, and you will get a lot of antibody that will block the fusion step. But if you have the post-fusion version, which is a completely rearranged version of this protein in the vaccine, then these antibodies are useless. And so the problem is that often when we make vaccines and when we inactivate them, these spike proteins spontaneously flip over from the pre-fusion to the post-fusion step. And even if you make them as recombinant proteins, that happen. And so what was done for SARS-CoV-2 was mutations were introduced that arrested this spike protein in the pre-fusion conformation. And for SARS-CoV-2, this was basically the introduction of two prolines at the region that forms a hinge in the pre-fusion conformation, but is a long helix in the post-fusion conformation. And prolines are amino acids that don't allow helix formation, right? So basically, you just arrest this in the pre-fusion conformation. That was a really nice trick that worked well. And so exactly the same was done for these vaccines against RSV now. So you have the fusion protein here, the F protein, which is also a spike protein. And this is how it looks in the pre-fusion conformation. And this is how it looks in the post-fusion conformation, completely different. And actually, when you make inactivated RSV vaccines, like they have done in the 60s, all the F protein is in the post-fusion conformation that you have in the vaccine, and that doesn't help you. And so basically what is used now by these vaccines, from GSK and Pfizer, is a modified version of the F protein that cannot go into this post-fusion conformation. And that makes it work. And so we didn't know a lot about this 10, 15 years ago until the structures of these proteins were solved, and we could start to, introduce mutations, rational mutations that would arrest it in the pre-fusion conformation. So this really made it possible. And one of the big players who kind of worked on that was Barney Graham and the Vaccine Research Center at NIH. We're seeing this technology now used for other vaccines as well. All right, and for the last few minutes, I'm going into influenza. So influenza, you have probably a pretty good idea about influenza virus, but in general, influenza is not just infecting humans; it infects a lot of different animals. It has an extremely wide host range. It does cause a spectrum of mild to severe respiratory disease in humans, like these other two viruses. It causes similar disease in mammals, but in birds, it's often asymptomatic. And for humans, we have two forms. We have epidemic or seasonal influenza, which is caused by influenza A and influenza B. And then we have pandemic influenza, which is only caused by influenza A. Just to give you a few numbers, typically for seasonal influenza, we see 3 to 5 million severe cases every year worldwide, and between 300,000 and 650,000 deaths. And in the US, this fluctuates between 3,000 and 49,000 deaths per year. And then in case of pandemics, I think the strongest example is the H1N1 pandemic of 1918, which claimed approximately 40 million lives. We do have a lot of countermeasures for influenza. We have licensed vaccines against this seasonal influenza. These vaccines are typically quadrivalent. They have an H1 component, an H3 component, and 2 different influenza B components. And we have the regular inactivated influenza vaccines, which are commonly known as flu shot. We have recombinant protein versions of the vaccine, which that vaccine is called Flublok, and that works relatively well. Of course, there are intranasal live attenuated flu vaccines for kids, FluMist. And then we have two formulations, the high-dose influenza vaccine and adjuvanted influenza vaccines that are specifically made for the elderly, and they have a little bit of higher efficacy in elderly populations. And then, of course, there's also several antivirals that work well when they are given early. Influenza in the population is relatively complex. I'm not going to walk you through all of this because I don't want to spend too much time on it. But as you can see right now, there's H1N1, H3N2, and also influenza B circulating in humans. And so before the pandemic, we had these seasonal outbreaks of influenza, and this is shown here for the northern hemisphere in the upper panel, and then for the southern hemisphere in the lower panel, so typically during winter season. But when COVID-19 started, we saw something remarkable. There was basically no flu circulation in the season following the pandemic. And this is very likely because there was very little air travel, and because we had all these non-pharmaceutical interventions, including masking and social distancing. And this is, of course, very interesting also because if there's less virus circulating, the virus goes through a bottleneck, right? Through a genetic bottleneck. And that's exactly what we saw. So before the pandemic, we had a lot of different clades of H3N2, which you could think of as variants. We had a lot of H1 variants, and then there were two lineages of influenza B virus. And right now, this genetic diversity is very much reduced for H3 and H1. And one of the influenza B lineages completely disappeared. The Yamagata 1688-like lineage is basically gone. Only the Victoria lineage is still circulating, but also has less genetic diversity. And the nice thing about this is it was really hard to select vaccine strains before the pandemic because there was so much diversity. And now it became much easier. And so the idea is, at least in this season, the vaccines will match very well the circulating strains. Of course, influenza is now back. So you can see here in pink, the 2020-2021 season. So there was basically no influenza. But in 2022-23, virus came back. And the expectation is that we will have a regular season this year as well. This is just the data, the current data from CDC. So right now, there's very little activity. There's always a few cases, but it doesn't look like influenza season has started yet. And typically, we see an increase in the end of November, beginning of December. And this is my last slide. I just wanted to make you aware of something that you might not be aware of. So we have, of course, these seasonal influenza viruses that circulate in humans. And these are bona fide human influenza viruses that we have been dealing with for a long time, but there's a lot of different other influenza subtypes out there in animals, specifically in birds. And so in early 2022, a highly pathogenic avian H5N1 virus made it to the Americas. This virus was prevalent in Europe and in Asia, but somehow via Iceland was introduced in North America. And since then, we have seen this virus spreading throughout the Americas. It's now even down in South America. And it's very deadly for many avian species. So we have seen a lot of die-offs of wild birds. And of course, it's also an issue for the poultry industry because it gets into poultry farms and then all the birds have to be culled. And that has an impact on egg and chicken prices. But we have also seen that these viruses can infect mammals, specifically mammals that would feed on carcasses of dead birds, including foxes, for example, as you see on the right side. And we've also seen infections in pets, in cats and dogs. And when the virus infects mammals, it causes respiratory tract infections, but also neurological symptoms and often death. So far, we had very few human cases, and only after direct contact with infected birds. A handful of them were mild, and two in Latin America were severe. But I wanted to make you aware that this virus is very common in birds in New York City. Even in Central Park, these infections are common. of course, in birds, not in humans. But I think clinicians should be aware of this when treating patients with severe or atypical influenza, especially outside of the season. If you want to know more about that, there's also an overview article that I wrote with Stacy Schultz-Cherry from St. Jude's Children's Hospital a while ago that has more information about this. But this is certainly something to watch. I don't think there's a pandemic threat right now, but zoonotic infections are possible, and H5N1 viruses are known to cause severe infections in humans. And this brings me to my kind of conclusions and outlook. I think we have to think a little bit more about, fighting respiratory infections and take what we've learned throughout the pandemic and apply it now moving onward with our regular respiratory infection seasons. I think in general, it's important to tell people to get vaccinated. And we have antivirals for a lot of these, for influenza and SARS-CoV-2, and we need to make sure that high-risk patients, when they get tested positive, get treated immediately with antivirals, because only if you treat quickly, these antivirals actually work. In general, and I'm starting to practice that too, it makes sense to continue masking inside when there's a lot of virus circulating. And I think that's specifically important for a hospital setting. But for example, if I take the subway, I wear a mask right now. And this is another important point, that infected or sick individuals should stay home. A lot of people come to work when they have a common cold or when they have any kind of respiratory infections because they don't want to miss out on work. And then they infect other people, and that's how viruses spread. If you're infected and you stay at home, your virus also stays at home and doesn't infect anybody else. And I think in the future, we have to invest more into getting additional antivirals, because there's always the worry that we see resistance. For SARS-CoV-2, we only have Paxlovid that works well right now. And if viruses that are become resistant, we don't have anything anymore. I think it's important that physicians and patients are informed about available treatments. In my opinion, having masks in a healthcare system being mandatory during the winter season would be a good idea. I know that it's uncomfortable wearing those masks and a lot of people don't like it, but I think it would cut down on infections quite a bit. But I think also from a engineering perspective, we know now that proper ventilation systems really cut down on infections. And I think we should think about that when thinking about infections in schools and hospitals and universities and workplaces in general. And I'll finish here, and I'm happy to answer any questions.
Wow. That's a lot. And wow, we really appreciate this update. It's amazing how quickly things have changed even since last year. So I know we have a couple of questions in the Q&A. Are there other coronaviruses in animals that are being monitored for transmission to humans, mammals, and posing a risk?
Yes, there is actually a bunch of coronaviruses that everybody's worried about. Most people don't know that, but we had a zoonotic event in, I think it was Indonesia or Malaysia, with an alpha coronavirus that jumped from dogs into humans a few years ago and caused severe disease. It didn't spread in the end. There is, of course, MERS coronavirus, which is prevalent in camels in the Middle East and spreads to humans occasionally, and has caused a large outbreak in South Korea in 2015, which was contained. So there's a lot of these viruses out there that cause trouble every once in a while, but they are monitored. Not as well as influenza is monitored in birds, but there are programs to do surveillance and to, look out for these infections.
I had a question, which when you talked about the people with prolonged illness being sort of a reservoir for all of these mutations to take place. So you said, I think you showed a patient who had 81 days or something like that mutation. So is it just that there's more time? I mean, is it the same as if 30 people have had the virus for 3 days, that 81, that somebody with 81 days is one person, or is there something special about the fact that prolonged illnesses cause mutations to happen even more quickly?
No, I think there's something special about it, because even if you would calculate the error rate and how much a virus would change if it would infect this a set number of people in a set number of time, and then you compare it to a persistently infected person, there's much more change happening in that persistently infected person. And one hypothesis right now is that, a virus is not monoclonal, right? It's a quasi-species. There's many variety. When you get infected, there's different varieties. There's, clones that mutate, and another clone has a different mutation. And coronaviruses actually can recombine, meaning when two different coronaviruses infect the same cell, they can just recombine their genome, right? And so what we think could happen is that in these patients, there's a lot of diversity of viruses over time that builds up with, a few mutations here, a few there. But then you also have recombination events, and that might speed up evolution. And of course, it doesn't help that these people, so what you would see in a lot of these people is that they have partial immunity, right? They have some immunity that puts pressure on the virus, but they can't clear it. And so the virus mutates because it wants to relieve that pressure. You have a lot of variety of viruses there. They recombine, and you basically end up with something that has, 20, 30, 40 mutations.
Okay, there's another question. Last fall, we saw a huge RSV season with spike in cases in New York City compared to previous years' RSV. Even though there are new vaccines, would we expect that RSV wave from last year will produce some natural immunity for this year?
Yes and no. So an RSV infection doesn't necessarily give you protection from a subsequent infection, although probably, if you had it recently, there will be some. And as I said, there are two genotypes. There's RSV-A and RSV-B, and there's some evidence that there is also, escape by just being different, right? So if you had RSV-A, probably protects you better against RSV-A than RSV-B. But I wouldn't expect a huge wave this year, but I would certainly expect cases.
Are we closer to monitoring antibody response to determine a need for vaccination and booster for COVID-19?
No, we're not, because the problem is, again, antibodies correlate with protection. That has been shown now many, many times. But you need to look at neutralizing antibodies, and it is really hard to come up with a routine diagnostic test that measures neutralizing antibodies. And I think that's kind of still one of the issues, and I don't think there's much development in that direction at this point in time. It's the same for influenza, right? For influenza, you could measure neutralizing antibodies, but there's no, just regular tests that you can order that would do that. We can do that in the research lab, but it takes a few days. It involves a biosafety level 3 laboratory, and it's relatively complex.
So I'm going to ask you a question that's slightly outside of the scope of virology, but very important to things that we're involved in. And that is, we've basically pared down our hospital beds and everything across the city to where we, every day as a department chair, I get a notice, please discharge people as quickly as possible. There are no beds. And so we've created a system that's got almost no surplus capacity anywhere. And yet we saw what the impact of that was with the last outbreak. So with all these viruses, is it almost inevitable that we're going to have at some point another pandemic? Maybe not as bad as the last one, but where we will need some excess capacity in the healthcare system, because Mount Sinai is about to shut down another hospital, which is Beth Israel, and I just worry about the fact that we have no excess capacity in the system, and people like you are basically looking at this, going like, "Oh my God, if this thing comes from birds, we're skunked for another, season." And what do you think?
So We had a respiratory virus pandemic in 1918, one in 57, one in 68, another one in 2009, and then one in 2019, 2020, right? It's just a matter of time. My estimate is for my career, until I retire, I will see 2 more pandemics.
Wow.
So, there are factors that actually suggest that we'll see more of it, because most of these viruses come from animals, right? And there's more people on this planet, and there's much more farming, and so the interface between humans and animals is bigger. And climate change doesn't help, and habitat destruction doesn't help either. So with those factors in the very connected world, it's very likely that the frequency of pandemics goes up. And it could be something that's relatively mild. Pandemic doesn't mean that it has to kill a lot of people. It's just, so disease that spreads globally. But there are viruses out there like Nipah virus, which is currently an issue in Bangladesh and India, that show some evidence that they could transmit from humans to humans, and they have case fatality rates of 50, 60+%, right? So it could be worse, it could be much milder, it could be similar, but I think it's just a question of time until the next pandemic comes. Maybe it's 10 years, maybe it's 50 years, maybe it's 5 years.
There's one last question, and then we'll let you get back to the lab so you can cure a few more of these diseases. Should we retest patients until they're negative? I guess this is about COVID.
So yes and no. In general, retesting is problematic because people can stay nucleic acid positive for a long time, right? We know that the PCRs can stay positive for quite some time, even though the patient might not have any infectious virus left, right? Where I think this is a good idea is people who still are symptomatic, people who have a known issue with their immune system, where you would suspect that there is actually a persistent infection going on. But for a healthy adult who, kind of recovered, I don't think it makes sense.
Well, thank you. As usual, we're going to book you for next year now so that we can make sure we get you on the schedule. It's such a pleasure, because your presentations are so clear and also so important to keep us updated, because our patients are asking us these questions all the time, and it pays to actually be able to say something that's intelligent and truthful and not just repeat what we read in the newspapers or online. So it really, it's wonderful that you could join us again. We really appreciate it, and keep working on this and keeping us safe. Thank you so much.
Thanks for the invitation.
Sure.